we give cancer cells far too much credit. They don't know what color we are. They know which processes, what they need to grow. And that happens whether you're black, white, or purple. So cancer cells don't see color, people do. Equity of care is so important to all of us. We all deserve high quality cancer care. It doesn't matter who we are, what our names are, where we're from, what we do, we all deserve high quality care. So we have to make sure that all of the latest advances reach all patients that need it.
Statistically, Black women are more likely to develop aggressive forms of breast cancer and to die from the disease than white women. And unfortunately, for too many of our patients, this isn't a statistic. It's their life. So why is this? Today, we are going to do a deep dive on this topic with Dr. Lori Pierce, who is the president of the American Society of Clinical Oncology, the preeminent association for cancer doctors. A radiation oncologist, Dr. Pierce has chosen to focus on the theme of health equity in cancer care as the theme for her term as president. Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. I am so excited for all of you. We have Dr. Lori Pierce, the president of the American Society of Clinical Oncology, here with us today, our most esteemed guest, and we are just so excited to have you.
I am delighted to be here. I think the idea of having this cancering program is a fabulous idea and gives me a chance to actually talk to people in the community. And so I am thrilled to be here. Thank you so much for the invitation to join you.
Well, that was actually my first question. So I know you get invitations to do press all the time in your role for ASCO. What made you want to talk to us here in the Deep South?
So first of all, I'm a radiation oncologist. I'm a breast cancer doctor, and I enjoy working with people. And I try to connect with listeners whenever I can. Sometimes my schedule doesn't allow me to do it as often as I'd like to, but you, Dr. Pierce, provided such flexibility to do this. And it's such an important idea, being able to talk to people and answer questions about cancer, that I was thrilled to do it. And given the flexibility that you created, this was definitely something that I wanted to do before the end of the year. And I have to just brag on you for just a moment, if you'll let me do that. So for those of you in the community who don't know, Dr. Jennifer Pierce is part of our ASCO Leadership Development Program. And that program is a program that is highly competitive. We pick 16 people every year out of just so many competitive applications for people who are stars, for people who are stars in the oncology community, who already have shown their expertise and their ability to do something exceptional for patients. And they are the future stars of ASCO. And Dr. Pierce is one of our members, one of our participants in the LDP program. So I was thrilled that she asked me to do this, and I am just thrilled to support this effort.
Thank you so much. And thank you for saying that. I think that this type of opportunity is where I really want to leading, kind of connecting, as you said, our community members to the latest, greatest information, to making sure that people have accurate information at their fingertips and meeting people where they are. So we really appreciate this Zoom-based journey down here to Mobile. So we conceived, and I can't take credit for the name, Carol and Johnny conceived of the name, The Cancering Show. What does the word cancering mean to you?
That stumped me. I'll be very honest, and I kind of pride myself on being aware of a lot of the cancer lingo. And so I had to think about that. And I have to believe the cancering program really means the totality of how cancer affects us and how we process it and how we understand it. Cancer, as you know, affects so many parts of our lives. Some of us are currently being treated for cancer. Others have already been treated for cancer. We all know people who have either had cancer or cancer survivors or perhaps have succumbed to their cancer. So cancer is everywhere. It's a part of our life. And it's the processes that dictate cancer are going on in us all the time. Cancer, as you know, and maybe some of your listeners know, basically is an uncontrolled growth of cells and the potential for cells not to obey the rules that we set up for cells to obey. We have corrective processes. We have processes that make the cells follow the rules. And so that errors that can allow a cancer generally don't happen, and we keep these cells intact. But sometimes there are changes in our DNA. Those are the parts of our cells that dictate cell growth, that either you can be born with genetic changes or come with the environments or chemicals, viruses, whatever, that allows these changes to happen and evade those corrective actions that we have. And then that's when cancers can happen. So I guess it's a long answer to your very short question. Cancering is really understanding what cancer is, how it affects our lives, and what we can do to treat it if we're diagnosed, and what we can do to prevent it. So it's kind of like a continuum. And I'll just add something. Yes, I am ASCO president. I'm honored to have been selected as ASCO president. And my theme is equity. Every patient, every day, everywhere. And equity of care is so important to all of us. We all deserve high quality cancer care. It doesn't matter who we are, what our names are, where we're from, what we do. We all deserve high quality care. And that factors into the cancering part of it, how we handle cancer, how we process it. And equity of care is so important to me.
That's it exactly. We chose that name because it encompasses the before, the during, and the after, that cancer is just not one moment, but that verb, that continuum. And I like that you talked about it even at the very scientific molecular level. There's a continuum all the way up through how it affects our lives. You couldn't have done a better job of opening up to my next question, which is to talk about your theme, being the first African-American president of ASCO, choosing a theme of equity. What made you want to move ASCO in that direction?
So first of all, let me just say ASCO was already in that direction. And Dr. Pierce, ASCO so well. ASCO, everything ASCO stands for includes quality of care and equity in care. And so ASCO already was in that space. But what's interesting is, you probably know in ASCO, when you are initially told you've been voted president and you're shocked and you say, okay, I'm going to be president of ASCO. It's in your year before you become president and you have time to think of a theme. And so it was in that time that I said, clearly I wanted to be equity of care because it's been something that's been very important to me as an oncologist, as a woman, as an African-American woman. So it was very clear that was going to be, but that was at a time long before we even knew there was such a thing called a pandemic. That was COVID. That was at a time that, yes, racial inequities and racism have been there for years and years and years in this country. But it was before we started seeing it every night on TV. And so I chose this theme, and when I chose it, I thought, are people really going to rally around it? Oh my gosh.
Right.
As people rallied around it, I cannot think, and I'm not patting myself on the back. It's just the sun and the moon were aligned. This is absolutely the right time for that theme.
Absolutely. It's just obviously so necessary, something we've been feeling in the Deep South for a very long time, something I think the entire country feels. And in every place it's different. Equity is not just about race. It's about rurality. It's about, as you talk about, getting discoveries from an ASCO meeting. It could take 20 years for that discovery to hit rural Alabama. And so how do we speed that up and create that high quality new discovery, equitable care across this country, what everybody deserves? And I think some of it is things like this, telling people what they deserve. So I guess my question to you is, how do you take this large concept and ASCO, the meeting of the elite minds in this country, and take that message or that information to the patient in a rural cancer center in Middle America?
All patients deserve high quality care, so we have to make sure that all of the latest advances reach all patients that need it. And as you know, the majority of patients with cancer are seen in community practices. So they're not seen necessarily in the academic centers. And sometimes it's general. The academic centers may be places where there are the most up-to-date therapies. And so we have to make sure that that knowledge is translated to the providers that are often closest to the patients. And so it's important to set up networks, meaningful networks between academic centers, providers, and our community oncologists, because it takes a village, right? We all are working together to be able to reach the patients that we need to serve. And so those networks are very important to setting up clinical trials and exchange of information. One of the things, maybe the only positive that has come out of the pandemic, is that we realize that being able to exchange information virtually is something we absolutely can do.
Yes.
And so we have telemedicine connections with our patients. We also have telemedicine connections between academic centers and rural providers so that they don't feel like they are marginalized. And as long as the providers are on the same page, they will help us with disseminating the information to patients. And so we clearly have to have that two-way dialogue with our community providers, especially, as you said, for patients who are in the rural communities.
Yeah, absolutely. I love the idea of really that bi-directional flow of information, getting the patients to clinical trials, getting the information out to our more rural cancer centers and local oncologists. It's just so important. Along that theme of equity, I know you once said, cancer doesn't know what color you are. Explain that statement to our listeners.
I say that often to my residents. That I say we give cancer cells far too much credit. They don't know what color we are. So cancer cells know what it takes to allow them to grow. They know which processes, what they need to grow. And that happens whether you're black, white, or purple. Cancer cells know what they need. So cancer cells don't see color. People do, right? And so here you have the biology of the tumor with what it takes the cancer to grow. And here you have the social aspects of cancer care by what people think could be the appropriate therapies or not for certain populations. And therein comes in the social determinants of health, which is such an important piece to explaining the differences in outcomes that we see for certain populations. And certainly minority populations are among those who, in just about any comparison, you'll see less favorable outcomes for people of color for certain types of cancers.
Yeah. How do we take that information and translate that into action items for our patients, particularly patients of color? Whether we're talking about COVID or talking about cancer, I see so much despair that it feels inevitable that a person of color will be hit harder, that a person is more likely to succumb to the disease. How do we turn that message into action? Is that on the part of the provider, the family, the cancer patient? What do you think?
Dr. Pierce, I think that's a really important question. And, when I have the opportunity to speak to people of color and they ask me about the outcomes for people of color, I'm always obviously very, very forthright and say, yes, if you look at most cancers, you see less favorable outcomes, but there are things that we can do to kind of dictate our own outcomes. So many cancers, up to about 40-45% of cancers, are preventable. We can prevent them by how we live our lives, modifiable risk factors. And if you can prevent up to 40-45% of cancers, you can prevent up to, in some cases, the data shows up to 40-45% of some of the cancer deaths. And so there are things that are within our power, within our domain to control. In a time when we feel like there's very little control, this is one thing that we are able to control. And if you look at those modifiable risk factors, and I know that you know this so well, smoking, you cannot find a factor that is more preventable and has more impact when you prevent than smoking. And smoking, we know, causes lung cancer. It also causes many other types of cancers as well.
Absolutely.
So for those in the audience who don't smoke, fabulous. Don't start. For those of you who smoke, stop. This is a huge, huge impact. It makes a huge impact in terms of outcome. There are other things we can do. Alcohol. Minimize your alcohol, your drinking alcohol intake. Not drinking at all is great, or maybe having a glass of wine every once in a while is fine, but minimizing alcohol intake is very big. Obesity, exercise, diet. Most people don't realize, including some providers, that obesity is absolutely linked to certain cancers. Breast cancer, colorectal cancer, endometrial cancer, prostate cancer, some of the most common cancers. And, we have to be very careful with our diets, low-fat diets, get those grains, get those fruits and vegetables, all the things that you kind of roll your eyes at, don't, because they really do make a huge difference in terms of being able to prevent certain types of very common cancers, especially in the African-American population. These are cancers that are very common. Vaccines. We're hearing a lot about vaccines these days.
HPV vaccine. That's my soapbox.
HPV and hepatitis B. Those, right.
Yes.
These are viruses that we can prevent with these vaccines. And then so well with being a GYN oncologist that we will see a dramatic reduction in cancers. And it's not just GYN cancers, there are many cancers. So head and neck cancers, many cancers. So, there are things, minimizing your sun exposure. I'm talking to someone in the South. I don't have that problem because I'm living in Michigan where it's cloudy all the time, it seems like, but it's a nice problem.
It's a big problem here.
Use sunscreen. You don't go to tanning booths. You don't do those kinds of things. You really have to think about what we can do to have a healthy lifestyle, because it helps you on many levels. One, it helps to minimize the risk of certain cancers. And two, it helps to keep us healthy overall. So if we are diagnosed with a cancer, we have the ability, we're strong enough to be able to take the therapies for our cancer. So it's what you call a win-win. And then last thing I'll say, early detection.
Absolutely.
So important for everyone, all of us, to work closely with our primary care providers. And they have a checklist of early detection, things that we should be doing in terms of colonoscopies, in terms of mammograms, in terms of, a list of things. And we just need to make sure that all of those boxes are checked.
Absolutely. And there are some cancers, I think prostate in particular has a risk factor for only testing for risk factors, and that is particularly African-American men fall into one of those risk factors that I think sometimes those guidelines are even different, that we need to think about it and know what your risk is. And of course, the other one we've talked about on this program is family history, knowing your family history, discussing it with your provider, seeing if there's a need for genetic counseling or testing, and then following up in particular on those screens for cancers that run in families.
Absolutely. Yep.
What makes you hopeful about cancer and equity of care?
We have seen so many advances in cancer care. And if you look at the survival rates, you see that the survival rates are improving for all populations. We don't see the same rate of improvement for people of color as we do for our white patients. But I think, again, that goes back to social determinants of health and also modifiable risk factors. And so we are clearly moving the needle in the right direction in terms of more effective therapies, in terms of individualizing what we do for patients, realizing that less is sometimes more, that sometimes doing less gives you just as good an outcome in terms of your cancer outcome, and it's a better quality of life.
Absolutely.
We're learning a lot in terms of clinical trials, and I'll come back to that point in a minute. So I am very optimistic. And then you have low bias organizations such as ASCO, which works very, very closely with our lawmakers on a local level, on a state level, and on a national level, so that we can advocate for the needs of cancer patients that will help things such as the social determinants of health to kind of even the playing field. So I am very optimistic, and I'll share this with your listeners. I'm from DC, Washington, DC, and I moved to Michigan. I've been here for a long, long time. But my father's family is from this small town in North Carolina called Ahoskie. And when I was a child, I used to spend a good part of my summers in Ahoskie. And Ahoskie very segregated. And so at that time, the care of African Americans was pretty much by one physician. It was an African American physician who was superb, but it was one physician. And I have seen significant improvements in health. There are a lot of Ahaskis in America, right? And I have seen for myself much more equity of care. So equity of care overall, in conjunction with the equity of care and the efforts for cancer, I am very optimistic for the future.
That's fantastic news. You wanted to come back to clinical trials, and I did also. We know that African Americans in particular and people of color in general are much underrepresented in clinical trials across the country. I'm very proud to say that at South Alabama, our rate is 23% enrollment.
That is wonderful.
Yeah. And we're so proud of that. But, it's really trying to think about how that translates into teaching other people how to do it. One of the things that I think is just so important at our cancer center is not being afraid to ask. In Alabama, in a place that's not that far from Tuskegee, obviously mistrust and misinformation are always a factor. But I think too often across the country, patients aren't approached because of a presumption of decline or a presumption of mistrust. And our number one thing is to ask, to make sure every patient who qualifies is presented with the option. And patients are much more likely to participate than not across the board.
So I could not agree with you more. You're so smart. So we are, as you probably know, we have a initiative, and one of my initiatives this year as ASCO president is that we are collaborating with ACCC, the Association of Association of Community Cancer Centers, to improve the enrollment of minorities on clinical trials. And the reason of that is clinical trials represent the most state-of-the-art treatment. And it is so important that everyone, all cancer patients, have the option of going to clinical trials. And as you said, we see disproportionately a lower percentage of patients on clinical trials who are minorities. And the reasons are multifactorial, and certainly there is a piece of that. And as you said, you're sitting near Tuskegee, which is the poster child for mistrust. But as you know, we all have learned so much through the years about the importance of putting guardrails on that Tuskegee can never happen again, that there are so many steps for informed consent, that the patient is fully aware of the pros and the cons, and they make a well-educated decision. And by doing that, again, you have the option to go on clinical trials. And there was a paper that was published, or I think it's now out. It was certainly accepted recently, that looked at patients who were given the options of going on clinical trials. It was actually a analysis of a lot of the studies that have looked at this, and looked at white patients versus Black patients. And there was no difference. It was about 50 to 55% of patients who are offered a trial, whether you're Black or white, go on a study. So the Tuskegee experience is something none of us should ever forget. We should never forget it. But this experience tells me that patients move on. If you explain to them, whether they're white or Black or purple, what the trial is, people make the same decisions at the same rates. So that is a very important piece. And I think it underscores what you said, Dr. Pierce, is that we have to present these trials to all patients and not have our own biases that, they probably won't go on it because they don't trust me. You present this trial to everyone who would be a possible candidate for the trial, and let the patient decide. This should not be a physician preconceived bias.
Yeah. And hopefully for my whole generation, but certainly for me, that's how I practice medicine. I am here to give you all the information you need to make an informed decision, whether it is, between experimental therapy and standard of care, or between two standard of care options, or for second, third, fourth line, making tough decisions that are based on limited information and kind of very, very much patient preference. I try hard not to tell people what they have to do, but rather to say, these are your options and pros and cons of each. And I hope that that's a place that we're all moving into.
I completely agree. And I guess I should have qualified what I said. it's not just physician bias. Sometimes physicians just don't have enough time to explain clinical trials. And so I think there needs to be a further enrichment of the team so that it's a team effort. It's so you have others working with physicians so that collectively patients can be offered clinical trials. And I'll say one more thing. It's something I said to another group, and that was that, yes, there is certainly mistrust in some segments of the population for participating in clinical trials. But the irony is, since we know that clinical trials offer the best possible care, that if you're questioning whether your health provider is giving you that care, if you go in a clinical trial, you don't have to question it
Right.
because you are getting the best possible. So it actually going in a clinical trial will guarantee that you're getting the best possible care. And so it's just, you have to understand the importance of going on clinical trials for the best possible outcome.
Absolutely. This is a tricky question to ask, and I think it's ultimately in our lifetime going to be trickier to answer. There's been so much racist studies done in biology of differences in race. And yet we are in a time where we're moving into very targeted, personalized cancer therapies that interact with our own biologies, whether it is T cell or HLA or genetic mutation, etc. How do we study biologic differences in a way that's not racist?
So that is a great question. And again, it comes back to what it takes to make that cancer cell tick. What is it that cancer cell is looking for? What turns on that? How did that cancer cell evade the protective rules that we have in place? And that is not a race thing. That is a biology thing. And so, again, I think that brings in discussions with patients, that brings in, it addresses the trust issue, but it gets away from the race issue because you're looking at the biology. And so I think clearly these types of initiatives should be made based upon the biology of the cancer and not the zip code of where the patient lives. And so, I often get asked, how do you separate the two between the social determinants, which gets into the economics of it all, gets into the neighborhoods that we live in, gets into the healthcare systems, the education, all of those things, and how do you differentiate them? There's a really interesting experience that some of the leadership of ASCO published many years ago, something called the Delaware Project. And I don't know if you're familiar with that.
I'm not.
So the Delaware Project, as you can imagine, took place in Delaware. It was in the early 2000s. And basically, it looked at the rate of colorectal cancer in the state of Delaware. You have a small state, so it's easier to do. And they noticed the huge discrepancies between the incidence and survival rates for Blacks versus whites for colorectal cancer. So they said, okay, we're going to start a program. We're a small state. We can do this. We're going to start a program where we screen everyone, all adults in the state, for colorectal cancer. And if you can pay for it, fine. If you can't pay for it, the state will pay for it. And then if we find a colorectal cancer, you'll be treated. And if your insurance pays for it, fine. If not, the state will pay for it. And when they did that, their differences in survival almost completely went away by race. And so the initial hypothesis was, this must be to a large part due to biology. No, this was not due to biology. This was due to the social determinants of who has access and who can treat their cancer. And it was a win-win because the cost of doing this was cheaper than if we did the usual way. So preventing and treating at an early stage, it was a cost-effective improvement. And so we at ASCO are dissecting that experience because we want to be able to bring that forward into other communities for many disease sites. But that gets at the heart of biology that the cancer dictates versus social determinants that people dictate.
My experience, I did an ancillary study for GOG looking at a trial that they had done for a drug that was found to be no difference and was not approved for treatment of cervical cancer, a phase 3 trial. Patients were randomized to either receive it or not, in addition to radiation cisplatin for standard cervical cancer treatment. And 75% of the women on the trial were white, and there was found to be no difference. And if you divide the patients into white and black, then there actually was a large survival difference in African-American women. The patients who received the drug, which works better in a hypoxic tumor environment, did better. And the patients who did not receive the drug did, and those patients did significantly better than the white women, both who received it and didn't. So in white women, it made no difference. And in black women, it made a huge difference. That's the kind of stuff that makes me nervous, to say that we haven't stratified many of these clinical trial findings between, not race, as you said, between markers of biology that we still don't understand yet.
Absolutely. I completely agree.
Yeah.
The fact that people are increasingly talking about this, people are now aware. I'm very optimistic for the future.
Well, I think that's a great place to bring our conversation to a conclusion. We so appreciate you taking the time to talk to us. I, too, am really hopeful for the future because of people like you leading this generation into that. And my time in the ASCO leadership program, again, gives me a lot of hope that there are leaders coming up to follow in your footsteps that'll take us into this future century of personalized medicine and equity of care. We really appreciate your time today.
It's all about leveling the playing field, right? And programs like this cancering show, you increase the understanding, you increase people's awareness, the audience's awareness of what's going on in cancer therapies and the importance of clinical trials. And it's things like this that level the playing field. So thank you so much.
Thank you so much for that. I've never thought of it that way, but Dr. Pierce, it means a lot for you to say that.
My pleasure. Take care.
Thanks everyone for listening to The Cancering Show with JYP, Dr. Jennifer Young Pierce. Please subscribe, rate, and review this show on iTunes and anywhere else you listen to your favorite podcasts. Want us to deliver The Cancering Show to your email inbox? Contact us at cancering.com and we can make sure you never miss an episode. We would love to know what you think about the show, or if you have any suggestions on topics you would like to hear. You can reach out to us on Facebook, Twitter, and cancering.com. Till next time, be healthy, happy, and always thriving.
This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond, with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.